Hi everyone, today I'm here with Dr. Chima, a rheumatologist who's been practicing for over 20 years, who's also a clinical professor of internal medicine in the Division of Rheumatology, Allergy, and Clinical Immunology at the University of California, Davis Medical Center in Sacramento. So Dr. Chima, thank you for being a part of this interview.
You're welcome.
And before we go into the details of rheumatology, could you briefly explain what rheumatology is?
Rheumatology is a subspecialty of internal medicine. It pertains to conditions, diseases, treatment of diseases which are caused by a malfunctioning immune system. It could be a disease like rheumatoid arthritis. It could be a disease like systemic lupus or scleroderma. But then there are other conditions which rheumatologists will also treat, and these would be more musculoskeletal conditions. They may or may not have anything to do with the malfunctioning immune system. So, for example, conditions like osteoarthritis, which is a degenerative arthritis, an age-related mechanical sort of breakdown of the cartilage in the joints. So a rheumatologist would be helping people deal with that as well. And then sometimes some rheumatologists, not all of them, would assist in managing people who have conditions like fibromyalgia, chronic myofascial pain as well. So basically it is dealing with conditions affecting the musculoskeletal system, those manifestations which are caused by the malfunctioning immune system, as well as mechanical breakdown of the body's tissue, especially the cartilage in the joints.
Okay, and what are the most common cases you'd see?
As a rheumatologist, if you look at the statistics, the most common disease which is affecting people now from a musculoskeletal standpoint is osteoarthritis. But for most rheumatologists, the most common disease that they would be treating is rheumatoid arthritis, which is, again, a condition where the joints get inflamed because of a malfunctioning immune system. Other conditions, other diseases we treat include systemic lupus, scleroderma, Sjogren's syndrome. There are people who have dermatomyositis, polymyositis. There are several other conditions we call vasculitis, which includes Wagner's, they call it GPA now. There are people who may have other similar vasculitides, polyarthritis nodosa. There are people who may have conditions like Behçet's, Cogan's syndrome. All of these are mostly rare conditions, but they also fall under the realm of rheumatology.
Okay, and what's a typical day in your life like from when you come in to when you leave?
Usually, it's a good question. It's an 8 to 5 job for most rheumatologists seeing patients. Patients usually start. The clinic starts at 8 a.m. Sometimes, some places it's 8:30, and the last patient is roomed around 4:30. For some, it's about almost 4:45 for some. So the clinical time period which we spend with patients is 8 hours a day. There will be a 45-minute lunch on the schedule, but most of the times that gap is taken up by urgent follow-ups. I need to be seen soon. So all right, to come and I'll see you on my lunch break. So that's the usual patient-physician interaction. But at the same time, you have to keep in mind that the technology, information technology advancing. Now we have, I would say, 3 parallel tracks, operating in a clinic. One is where we go see the patient face to face. The other one, through the computer, the electronic medical records, we'll be getting patients' messages directly through email. And then there's the third one, which comes in from the triage nurses who get phone calls from patients about certain flares, certain conditions, certain questions, medication refills. That would be the third line. And then the fourth and the fifth would be, as I said, pharmacies seeking patient medication refills, and also lab lab results which keep coming and we have to sort of keep track of. So that takes a good couple of hours later on after the clinic is over. You're done with your patients to kind of catch up with the day's messages and other stuff, doing refill requests and stuff. So typically, I think this is pretty common for other specialties as well. The day in the office is about 10 hours.
And you said that's pretty common to other primary care and internal medicine specialties?
I think so. You know, some may be spending more time, after they've seen patients. It depends on how many patients they see also, because nowadays, it's important for us to document through electronic medical records. Everything has to be put in order. Good thing that we have templates which help us kind of gather all the information which we need. In the past, it used to be all paper charts, and it used to be, in a way, easier for people like me who were trained back in the day, but I think having an electronic medical record makes things a lot easier nowadays.
And what's the most challenging aspect of being a rheumatologist? That's
a tough question to answer. You ask anybody about how well they enjoy their specialty, or even for people who are in other professions. There will be days when life's fun. And other days there are a huge bunch of challenges. And I think amongst physicians, the greatest challenge that is twofold. One is that for people with rheumatic conditions, we don't have any good lab tests. For example, people come in and I've got a rheumatoid factor, so I have rheumatoid arthritis. True? No, false. Because there may be so many other things which make people have a rheumatoid factor come back positive. So how do we interpret those labs and then convey the message to the patient that this is what I think is causing this abnormal lab, and this is what perhaps is the cause of your clinical problem? So that disconnect sometimes requires a very intensive discussion, talking to the person, gathering all the information which the patient might even not think is relevant. And in addition to this, then you have to identify and interpret the tests, and then you have to pick and choose which therapy would be the most appropriate one. Most of these therapies have, really life-threatening side effects if people are not monitored properly for them. So that becomes a challenge. I mean, how smart the individual is to catch your, instructions. Are they really going to adhere to those instructions? Those are challenging aspects of being a rheumatologist. But that's between the doctor and the patient and dealing with the disease. But I think that in this day and age, the greatest challenge that we deal with is having to work with insurance companies, getting approval for different therapies, and where they come back and say, well, this is not FDA approved. Well, they know very well that this is an effective treatment, but they're not going to allow it for this particular patient. But other than that, it's a very gratifying field. It has its moments, but by far, I think I wouldn't choose anything else if given another choice.
So what are the most rewarding aspects of rheumatology?
People come in completely disabled. They have lived through a lot of pain. And to see them walk again, do their things which they love to do the most, going back to their jobs, is the most rewarding aspect. For example, I saw a patient. He was in his late 30s. He was in the hospital, and he was on a ventilator. He had a tracheostomy done. He was on a ventilator. And his underlying disease was dermatomyositis. He was totally disabled. His muscles won't move. He couldn't use his arms. He couldn't use his legs. He was bedridden, basically. So on top of it, he also had lung inflammation. So with this interstitial lung disease, he couldn't get the oxygen in, the carbon dioxide out, and then the muscles were failing, and he was totally disabled. You see him today, he comes in running. He's normal again. I mean, he doesn't have enough muscle strength to go back and be a handyman again that he was before he got sick, but then he comes in and he's totally healthy. To see him get up from a bed, a hospital bed, which he was on in a nursing home, go to a wheelchair, go using a walker, going using a cane, and now coming and running and happy. It's the most rewarding aspect. One, that's the clinical thing. The other part is when people have seen other doctors, they have been given some presumptions, perhaps you have this, perhaps you have that, and they end up in a rheumatologist clinic, and you tell them what you think it is, and it turns out that's what it is. It's very satisfying for the patient that, yes, now I know what's wrong with me. And that helps other physicians also, It gives one a lot of gratification to be called as an internist with an edge. There are challenges as well, but it's pretty much a rewarding field.
And are there any misconceptions about rheumatology?
Yeah, I remember, I was doing my fellowship. I was at County USC Los Angeles, a tough place to be in, but I enjoyed every single day I spent there. I remember a resident come up to me one day and he said, "Doctor, I really love rheumatology, the way you solve these problems and all of this stuff." He said, "But, your review of systems is very extensive. I don't know how much time I can spend gathering all this information on review of systems. It takes less than 5 minutes. But then it gives you so much information. The problem now is that if somebody has chest pain, you go to the hospital, you see a cardiologist, he does a cardiac cath, and you know whether the arteries are blocked or they are not blocked. You get an answer, yes or no. You go to a hospital, you have stomach pain, they think you have gastritis, they send you to a gastroenterologist, you do an endoscopy, you see if this is gastritis or not. So if you have, you get treated. If not, then you get, referred to somebody else. But for a rheumatologist, it's not as straightforward. So the misconception is that what we deal with mostly is subjective stuff. So it is mostly dealing with pain. It is chronic pain that we are trying to handle every single day for every single patient. But that's not true. And like in our place, and as an academic institution, we don't have to deal with patients with chronic pain at all. Primary care doctors do take care of them. We do see them intermittently to make sure they don't have any other underlying rheumatic condition. But not all patients we see who have chronic pain are drug-seeking, or they have this some psych component which makes them kind of a very difficult patient. I think that was the misconception which is going on. When I was training, the misconception was, there are no treatments for any rheumatic diseases. All you do is treat with prednisone. So what's the fun being a rheumatologist? But that's not true anymore. I mean, maybe that was true at some point. Back then in the 1940s, when prednisone was first discovered, there was even a discussion, do we even need rheumatologists? We have cure for all autoimmune diseases. We got steroids now. But that was a very sort of a late realization that how the steroids can harm people. So, I think there are some, but a lot of people are now getting to realize the contribution to society that rheumatologists are making is really real.
Why did you choose rheumatology as a subspecialty?
Every individual has their reasons. Some people will say that, I wanted to help other people because, I myself was dealing with something similar. Some will say that it was my family member who had a certain illness, so I chose to become a rheumatologist. And my reasons are unique to me. So I don't think that my reasons would apply to everybody, at large. To be very frank, when I did my residency, I was raised in Punjab, in India. So I was training to be an orthopedic surgeon. And all that adrenaline flow, rushing to the emergency room, pushing gurneys, taking people with trauma into the OR, it was real fun. And when I immigrated to the United States about 25 years ago, I had a family. I had a young son, a little infant, and the rush for adrenaline was kind of receding, Now you want to kind of take things a little easy. So what could you be closest to in terms of joints and musculoskeletal exam and reading these x-rays was rheumatology. So I had this inherent, connection to musculoskeletal medicine. So that was rheumatology. But that's not what brought me into rheumatology, though. This is an interesting story. I was training at County USC when, like other third-year residents in internal medicine, I was made to present a grand round talk, and I chose the topic to be adult onset Still's disease. Adult onset Still's disease is very rare, and for some reason, the entire 3 years of internal medicine residents from interns to third years would gather in that auditorium, good 300 people, some fellows, some other division heads, and others would, get together on every Wednesday morning. It started at 7. For some reason, I don't know why, I ran into the chief of rheumatology, and I suggested to him, I said, Dr. Horowitz, David Horowitz was the chief of rheumatology then. I invited him to be at that grand round talk. And he came. And he came with his team of, research docs and then fellows, and they were like an entourage of 10, 12 people. At the end of my presentation, my mentor, he also took some questions. He, responded to the audience questions. And at the end of it, the chief of rheumatology raised his hand, and I said, well, I wondered, why is he even raising his hand? He's the chief of rheumatology. Why is he even asking a question? So he said, well, three points. Number one was, I've never heard a presentation so concise, yet in so much detail about adult onset Still's disease, so I congratulate Dr. Chima for it. Number two, it was about a question which somebody else had asked and my mentor had answered, and he wanted to add another point to it. And the third one was, and I couldn't believe myself, I was actually post-call on cardiology when I presented my grand round talk. I was in my scrubs and, totally unprepared for this. And he said, well, I think this is the first time in the history of USC that somebody is being offered a fellowship position without a formal interview. I hope Dr. Chima will accept his position as a rheumatology fellow and pick up his application. So, I couldn't believe my ears. He was saying this, and there was a big applause in the hall, and he came up to me and he said, I hope, please stop by. I think you'll make an excellent rheumatologist. And here I am, 20 years later, a rheumatologist at UC Davis. So that's how I became a rheumatologist. And each one of us has different reasons for, and I think more common reason why somebody would choose to be a rheumatologist is primarily their interest in internal medicine, number one. Number two, they could do a lot of other things. Being good in internal medicine, rheumatology is not the only field. But if they would choose rheumatology as their subspecialty, they would do it for the lifestyle. It's much easier on you. You have enough time for other things in life, yet you can still be engaged in treating people with their chronic illnesses. So if one is a good internist and wants to have enough time on hand, this would be a good field to be in.
So rheumatology, the lifestyle is a lot more flexible than other internal medicine specialties?
I would think so, yes. Again, it depends on where you are located. Mm-hmm. If somebody is located in an underserved area, for example, there are no other rheumatologists. Life could be very, very busy. Before I came to Sacramento, I remember being told by my colleagues that there were rheumatologists here who would work 7 days a week. And they was not because they wanted to make money, because there were so many patients. There were not enough rheumatologists. And they enjoyed doing it, I guess, and that's why they did it. But overall, looking at the flexibility in the schedule, there is no such rush to go see a patient like a cardiologist would have to rush to the hospital, or a gastroenterologist would have to rush to a hospital. There is not much in terms of an emergency which is something which the internist in the hospital, a hospitalist, or an emergency room doctor wouldn't be able to handle, and you really need a rheumatologist. So yes, lifestyle is certainly, I think, better than other specialties.
And are there certain personality types or qualities that are best suited in medical students who might be a better fit for rheumatology?
There's several things which drive our quests. What do you want to be and how much you want to, achieve in life. Now, for example, I went to school in Punjab, in India. I don't have any student loans. I don't have to. My father paid for my tuition, and it was hardly any money. We almost went to medical school, and it was almost free. Now you come to the United States, and you, with board and lodge, apart, separate, you have a loan of what, $150,000, almost $200,000 just with the fees. And then you become a rheumatologist. And then that's the lowest paying subspecialty. Are you going to look at the lifestyle? Or are you going to look for how are you going to get this burden off your back? So those people, even though they make a good rheumatologist, they might be compelled to choose specialties which pay much higher. Being an orthopedic surgeon pays much more. Being a dermatologist pays much more. Being a radiologist pays much more. Being an internist sometimes pays more than being a rheumatologist. So I think that the personality type, the question which you ask, people who like to read, people who like to invest in patients with chronic problems, they need to be willing to do this. It's not going to be an ER doctor personality. It's not going to be an orthopedic surgeon personality, who will make a good rheumatologist. This is a person who's willing to sit down, spend 1 hour with a person just talking about stuff, trying to figure out what's wrong with them. One has to be very patient. One has to be very sympathetic. One has to be very careful in choosing their words when communicating with others. How are these words going to be interpreted? If I say something and the patient thinks that I'm implying that they don't have this disease or they're making up the symptoms, that would be the last thing that the doctor wants to do. One of the residents mentioned to me, he says, I would really love to be a rheumatologist. And he said, but I'm not the nerdy kind. So I guess the nerdy kinds, end up being rheumatologists. But on a brighter note, it's been so gratifying that there are teams of physicians looking at this patient sitting in an ICU. And he's been in the hospital for a month. And there are different subspecialists coming in. And when they give up, they say, call the rheumatologist. And when you go in there and your assessment, your approach helps get this person better, it's very gratifying. And what is it from? It's the time which the rheumatologist has spent studying different manifestations of different diseases, which adds that value to that whole team of physicians taking care of that person. Together they couldn't. We can't pass the buck on. We can't say, call that person now, we give up. We have to find a solution, or there's no solution. So, you have to be a nerdy kind, a slow kind, which people might think of as, but as rheumatologists, we would bring our own value to the table.
Do rheumatologists end up spending, like you mentioned, like an hour? Are the patient encounters longer than the standard, 10, 15 minutes?
No, absolutely not. Now, for a academic center, the time spent with patients would be different, and there's a reason for it. Generally speaking, one can assess a patient with a rheumatic disease within 40 minutes. Rarely one would see a patient with long, complex histories, where you would spend an hour with them. All follow-ups, most follow-ups, I should say, would take about 10 minutes to 15, 20 minutes maximum. In an academic center, the time allotted for each patient is a little longer. It's because it's the residents, the fellows who are going to see the patient first, gather the information, and then present it to the attending. And then the attending goes in and he kind of tries to fill in the blanks, and then he talks to the person, and then he makes up a plan, and then that's what the patient is given information about. So the teaching part takes its time, the assessment part takes its time, and then dealing with the patient and educating them takes their own time. So in an academic setting, new patient slots would last for 1 hour. Follow-ups would last for half an hour. But most patients with rheumatoid arthritis, lupus, who are stable, who are doing fine and have no complaints, and that's what it is like nowadays with all the modern biologic therapies and stuff. People come in and how are you? I'm doing fine. Any questions, concerns? No. Well, I got this rash, or I was ill, and then I stopped the therapy for a couple of weeks. Now I'm fine again. The labs look good. Any refills you need? No, I'm fine. All right, come to the exam table, you examine them. Wow, your joints look pretty good. There's no stiffness. No, doctor, no stiffness. Everything's fine. 15 minutes, and you're done. Follow up, let's see you in 6 months. There will be patients who you will spend a little longer. Let's do this lab, let's do this x-ray, let's do this study, let's do a PET scan. I'm going to see you back in 2 weeks. So that becomes a little challenge because the schedules are so backed up. Finding a slot in 2 weeks becomes difficult. That's when I said earlier, you have to see this patient over your lunchtime. So it's not that long of encounter with patients in rheumatology. New patients sometimes might take an hour, but for most part, 40 minutes, 45 minutes is sufficient. Follow-ups 15 minutes, maximum 20 minutes.
For a med student interested in specializing in rheumatology, first they have to get into a internal medicine program and then specialize in rheumatology. What tips would you give a medical student to get into a competitive internal medicine program and then a competitive rheumatology fellowship?
That's a good question. I think one needs to know this before they make up their minds. I was a fourth-year med student, and I remember my mock final oral exams. And it was a hot summer afternoon. We were 150 of us standing in a queue in an outdoor porch. It was very hot, and we were standing in a single file, and we were all walking in through the door, and there were 10 standardized patients sitting in booths. And this is, I'm talking about 1980-something, 89, 90, in that range. We were supposed to look at the person, spend a minute with them, and we would see a goiter. Okay, this is goiter. Okay, this is sclerodactyly. All right, this is exophthalmos. This is alopecia. So you move from one patient to the other. It's not a multiple choice. You get a piece of paper, you make that diagnosis. I'm standing at this last booth, and the professor comes over and he grabs me by my elbow, and he says, "Come on, son, let's go score you." And he takes me to his table and he starts to look at my sheet and he says, "All right." So he looks at me and obviously I'm expressing I'm being upset a little bit. And he says, "Why are you upset?" I said, "You didn't give me my full minute." And he didn't. He smiled and he said, "Well, son, I could have given you 100 minutes and you wouldn't know what's wrong with that person." He says, "Go home and read." These words are still, are echoing in my head, and they are worth $1 million. How much would you like to be a physician, or how good a physician you would like to be is directly proportional to how much information you carry in here. So it's very important to invest your time in putting together all this information. Because with time, as you see patients, you would start to use this information in an appropriate setting and interpreting different disease conditions. This is not true for just rheumatology. This is true for any subspecialty. But from a rheumatologist standpoint, I think that you need to put in a little extra. Because as I said earlier, you can't pass the buck on. You'll need to know all the information. But one thing also you have to keep in mind, that you can't get all that information in. You will also learn in that process of seeing these patients, over the years. You'll create your own little style, and your approach to these patients. So no matter what you want to do, you don't want to waste your time in med school. You want to invest every single dollar you pay in fees and your boarding and lodging and all the loan that you have incurred to make sure that you get every single penny which you spend there. Not only would it make you a good rheumatologist, but it will make you an excellent physician. So getting the knowledge in is very important. Number one. Number two, when somebody wants to be a rheumatologist, obviously they'll do a 3-year internal medicine residency, and then it's a 2-year or a 3-year rheumatology fellowship. One thing which I think is very important for somebody to become a successful rheumatologist is that how much exposure you get to rheumatology. How many of those electives one spends in rheumatology? How many conferences on rheumatology is one able to attend? That gives you not a lot of information, but it gives you an edge. An edge which is enough for you to impress the rheumatologists you are working with, the faculty where you want to be a fellow, to impress them that this person is really motivated and interested in rheumatology. Nobody would want to have a person in rheumatology who doesn't want to spend time in reading and is really motivated to deal with people who are chronically ill. As a part of the second point also is get into this habit of writing up stuff. You don't need an attending to tell you, this is a good case to write up. You want to do a write-up on your own on a rare patient, send it to, even those online publications. Send your articles to them, send your pictures to them. Create a database of things which you have done, which will eventually help you to present when you create a CV and you're applying for a rheumatology fellowship. That really impresses people. I mean, how else are you going to, in that 15-20 minutes you spend with an attending, interviewing a man, trying to see what this program is about and how you can contribute to it? That's not enough. To have an edge, I think one needs to spend time through their internship, through their residency, gathering these cases with rheumatic conditions and writing up on them, because that's the only way you can seek credit for having seen them.
Okay, and moving on to more of like the employment or business side of things, what practice settings or employment types are rheumatologists employed in? Like, is there solo private practice? Is it mostly big groups? You obviously work in academics. Is there locum tenens work and things like that?
Again, this question is less issue with the subspecialty. I think it is more of a opportunity which one wants to avail. Most rheumatologists in bigger cities would work as a group. That's what the current trend is. It helps you to be under one roof. You can have coverage from the other partner. It makes life a little easier if you're dealing with a tough patient. You can, kind of do a curbside consultation. I think that's how most practice models are now being built. You join in as an employee and later on become a partner. Depending on one's personality, like me, I wasn't really interested in the business aspect. I guess the salary may have been a little higher, but being in an academic setting, you interact with residents, you interact with medical students, you interact with fellows. That teaching has a different sort of, it gives you a different feeling. And I think it makes life a little more diverse in terms of, how can one, prevent feeling burnt out. There are solo practitioners also, but not as many. Smaller towns or cities perhaps will still have solo practice. Larger cities will have more of a group practice, and then there will be academic centers hiring rheumatologists. Locum is not very common in rheumatology. Some people still do, like for example some groups like Kaiser, even UC Davis had a locums rheumatologist. These would usually be people who have retired and then want to make some money on the side, and they don't mind spending a few weeks in a different city and seeing patients there. So all of these will be different models.
Okay, and how well, you talked about this a little bit earlier, how well are rheumatologists compensated generally and compared to other specialties? And are there ways where rheumatologists could increase their income besides just working more?
one has to be prepared before they go into rheumatology that the compensation will not be what a surgeon or a gastroenterologist or a cardiologist would be offered. One would weigh that with the lifestyle. So compensation, I think that in the Sacramento region, the starting salary of a rheumatologist, some of our fellows have shared this information with me, would be offered anywhere between 225 to 240K starting salary. And that would be working 4.5 days a week. So they'll typically have 9 clinics, and then that half day on Friday afternoons or any other afternoon would be to catch up with paperwork and stuff. So for 5 days of work, that's what a rheumatologist would be paid. I haven't kept up to date with the salaries with other specialties. I think rheumatologists and endocrinologists perhaps make the same amount of money starting on, but this is perhaps the lowest paid specialty. Are there ways to supplement income as a rheumatologist? Certainly, especially when you work with a group of rheumatologists who have invested in an infusion room, say for example. There are several therapies, several medications which are administered as an infusion, and those get billed separately from patient visits to the clinic. That will add to the income which is generated by the group. We used to have an infusion room here, but being in an academic center, I'm just being paid a salary. So I guess somebody in the real practice would know, how much money they would make running a infusion room as well. I think it's a pretty good amount which they can make having their own DEXA scan in their office or having an X-ray, suite in their own office. That saves a lot of money, and most rheumatologists are able to read their own X-rays. They don't need a radiologist necessarily. So having an infusion room, DEXA, and X-ray in their office complex usually will allow them to create more revenue.
And you mentioned building your knowledge in medicine being one of the biggest tips you'd recommend. How do you stay on top of all the medical advances?
It's different now than it used to be when I was training. Back then, you had to spend time in the library. There were no computers. There were computers, but there was no database which is as comprehensive as is now. Up-to-date was just coming up when I finished my fellowship. Reading the books and textbooks, going to conferences is one way of staying up-to-date with all the latest information. One has to keep in mind that the amount of information you look for or seek is based on the amount of challenging patients you see. So if you're seeing more people, you generate more questions in your mind, you're seeking more answers. Most of this information that we gather here, seeing tough patients, one of them would be to use up-to-date. It's a pretty good tool to stay, up on most current therapies and recommendations. Sitting in your own faculty grand rounds, that helps. Discussing difficult patients, challenging patients, helps as well. But I think of all is when you start seeing more patients and refer to different texts and studies which have been done in the past pertaining to that particular disease, eventually would help you create a repertoire of information which helps. Finally, as a resident, as a fellow, the best thing that one can do is to work with an attending who is interested and motivated in writing so they can help one create more review articles and stuff. That is an excellent way of gathering, all that knowledge. And finally, it would be to see and teach, because the best way to learn that I've found out is to teach. So when you're teaching others, that way you learn yourself as well.
And you mentioned burnout and avoiding it a little bit. What tips would you give to prevent burnout and maybe also establish a better work-life balance?
Yeah, set up a practice in Hawaii, I guess, on the beach, right? No. Burnout is inevitable. One has to be aware that burnout will happen. Most people feel guilty about it. And that's why, our chief here, I love him, Eric Gershwin, a wonderful, chief of rheumatology and advocate for all of us here. He used to say, I met him this morning. He says this very often. If you don't feel like quitting your job through, the week that you are spending your time in it, something's wrong with you. So keep in mind that frustration affects everybody, whether it's at a job, whether it's your family, whether it's in society at large. So acknowledging that this will happen helps you to kind of not let it affect you that deeply. This is normal. This is going to pass away. This has happened. The other thing that helps to cope with it is avoiding working solo. That will add a lot to your burnout. Having a partner working in a practice where you have other partners who will be willing to cover for you, who will be there to give you advice on a tough patient, who would be willing to see your patient when you're traveling, you're not available. All of these things will lead to you feeling a little calmer, less anxiety, less stressed out, and so obviously less burnout. Taking vacations usually help, but vacations bring their own stress. So what I have found out is that vacations will help as long as they are staycations. Just back up. Just, go back into your, that state where you don't have to worry about anything. No travel, no nothing. You're just taking it easy for 3-4 days and you come back refreshed. Taking too many vacations is not good either, because when you come back, you have 100 emails to respond to and 200 messages from patients you have to go through, because when they come in next time and they say, "Doctor, I sent you a message, did you get it?" So that adds to another level of frustration. So I think that it's not that much of a challenge we deal with in rheumatology. Some people do get upset about having to see, this is when they are working for someone, having to see patients with chronic pain, fibromyalgia. Sometimes that adds to the frustration. People take it very personally. Physicians, as a responsibility to help someone, and they can't, and they burden themselves with that, they don't feel good about not being able to help someone. So that leads to burnout. So their approach to medicine needs to be more practical, and that will certainly help prevent burnout.
What changes in medicine, and maybe specifically rheumatology, do you see in the next few decades? Is it mostly going to be new medications, or
I think there's going to be a big change in how medicine works. For example, now I hope this is not true, but it's possible. There may not be any more radiologists. Artificial intelligence is going to read all X-rays and all your scans. They're going to print out a report based on those algorithms, what they see and what they interpret. The computer does. Thank goodness to rheumatology as a subspecialty, where I don't think a computer would be able to put in so much information as to what the person has to describe about their clinical symptoms, and it won't be able to interpret those symptoms. You will still need a real person to look at talk to the patient, look at the labs, interpret the labs in light of that conversation and that physical exam. So I don't see much in terms of practice of rheumatology in the next few decades. From that perspective, the job security isn't threatened. What might happen, though, is that we may have better therapies available. We may be able to order special blood tests and see, all right, so this guy has rheumatoid arthritis. And so rather than hit and trial with one medicine not effective, do second one not effective, do the third one, we may be able to run a blood test and choose which medicine is going going to be effective, which therapy is going to be more effective, and go to it right away. And the person responds to it, and end of story. You have accomplished remission. So from that perspective, I think there will be advantage in the near future. I think we will be able to find out what goes behind what causes osteoarthritis, one of the most common causes of disability in Americans as we grow older. So I think for rheumatology there is a lot of excitement around the corner. But for medicine at large, people going into medicine, I think the salaries are going to go down. You might not be making as much income. Not because there is enough physicians, it's because the insurance companies are going to take a better chunk out of what you do. And that's how the capitalist world works, and I don't know if there is anything which you or me as a physician can do to address that. It's not fair, but that's how things are.
So last question, what tips would you give us to become good doctors?
Be a human being first. Each one of us shares all our emotions the same way. If we start looking at people as people, you'll be a good doctor. If you start looking at people as somebody on the schedule, a medical record number, then you can try your best, you can be the smartest individual, but you won't make a good doctor. That's the humane side of it. It's extremely important. Recognizing that the other person is not sitting in front of you because he's either testing you or he's trying to derive some pleasure out of that appointment is very important. He or she is there because they need your help. And they consider you valuable enough to be able to help them. I think is a huge responsibility that a doctor has to realize. They may not know what's going on with that person, but to make statements which frustrate that individual, make them feel emotionally imbalanced, will not be fair. The final thing, and I think I put this on purpose at the third place, is how much knowledge you have. Obviously, a good bedside manner is not a replacement for clinical knowledge that one has. You could be as polite, but if you are not smart, it makes nobody better. So having adequate knowledge is very important. But at the same time, realizing that you are dealing with human beings who are seeking your help, they're not there to waste your time, is extremely important. And I think if you deal with your patients as you would deal with your loved ones, or you would like your loved ones to be dealt with, you would be on the right track.
Okay, that's a great reminder. So thank you again, Dr. Chima, for being a part of this interview, and thank you guys for watching. If you have any questions about rheumatology, you can leave it in the comment section, and I can ask Dr. Chima and get back to you. Let me know who you guys like me to interview next. Thank you again for watching, and have a great rest of your day. Take care.
Thank you.